Good afternoon, everyone, and thank you for being here for this symposium on screening for latent TB infection among migrants from controversy to consensus. My name is Poonam Dhawan from the International Organization for Migration. I am coordinator for this session and also will co-chair with Gerard Bryce. I'll let you introduce yourself.
Okay, so apologies from Ibrahim Abubakar, who was in another meeting. I'm the head of the TB coordinators unit in KNCV. It's called the Netherlands and Elimination, and I'm acting as the NTP manager in the Netherlands.
So the idea behind putting this symposium together was on this topic of LTBI screening for migrants and mobile populations, was in recognition of the fact that there is an urgent need for evidence-based guidance on LTBI screening. And we hope that through the presentations and discussions this afternoon, we come up with some ideas on the way forward for both research on the one hand and policy development on the other. So without further ado, we'll begin the symposium sessions.
Okay, thank you. So I'd like to introduce to you the first speaker, which is Alberto Matteelli. So he will speak on the evidence on effectiveness and cost effectiveness of latent TB infections management. Alberto is a professor of infectious diseases at the University of Brescia and formerly working with WHO in this field. Please.
Thank you very much, Gerard, Poonam, for this invitation. So I have no conflicts of interest for this presentation, and to get into this issue, I think we can given as quite widely accepted some facts on the role of latent infection in the epidemic of M. tuberculosis and how important it is in an elimination strategy. So we accept old figures will need to be updated. About 2 billion people acting as a reservoir for the infection, for the disease worldwide, and we say they have latent tuberculosis infection. We know they have 5 to 10% probability of developing TB during their life, so they are healthy, but they are at risk of developing TB in the future. The risk, which is calculated as 10-15% as an average, varies according to factors which are individual susceptibility factors or even more group susceptibility factors, that we have the capacity of stopping the reactivation process by using a preventive therapy, which has an efficacy of 60 to 90%. And based on a number of analyses of the harms and benefits trade-off, systematic testing and treatment of LTBI may, if the trade-off is favorable, or may not, if it is unfavorable, be recommended in a given population group. And finally, this decision is not only decided on the basis of effectiveness, but also on other elements, and which concerns costs and resource consumptions in the optic of the public health approach. But altogether, we have now a TB elimination framework, which is based on 8 components, and number 3 of these components ask us to address special needs of migrants and cross-border issues, and number 4 to mount a national policy for latent tuberculosis infection testing and treatment in well-identified risk groups. WHO developed recommendations on who should be targeted at population level for testing and treatment intervention, systematic testing and treatment intervention, and they recommended that some population groups, like people living with HIV, contacts, both adults and children, patients initiating a TTNF, receiving dialysis, going to transplantation, or having silicosis, should systematically be tested and treated. Then there is a second group where this recommendation is conditional, and a third group where there is no recommendation, or there is a recommendation against. And you see that immigrants fall in the middle one. The middle one, conditional, means that every single country needs to define, based on their epidemiology, based on their resources, based on their funds and priorities, whether they want to include or not immigrants in their target populations. Why and what was the process to put immigrants in the second category? The first element was, is there evidence that they have a higher burden on latent infection? And we are talking here of immigrants for high incidence countries, defined as countries with an incidence above 100 per 100,000. Do they have increased incidence of prevalence, of LTBI? And yes, if your measurement of infection is TST, you have basically 3 times higher burden of infection. If you use IGRAS, then you have a little bit less, but still 2.2 higher burden. And this is a meta-analysis of 23 studies all over the world. And then the second question is, do they have higher incidence of tuberculosis compared to host populations? And these are data published last year in the recommendation, which shows that in large numbers of countries, low incidence countries, specifically in the European region, then the incidence of tuberculosis is invariably several times higher in immigrants compared to the host population. But the most striking evidence for a recommendation of testing and treatment is, do we have evidence of increased risk of reactivation disease? And this is lacking because no studies has been properly designed studies has been conducted in immigrants on this issue. Of course, we have some clues. These are data from the Netherlands, show what is the time between the migration process and the time of developing incident tuberculosis. So a minority, 1 out of 5, occurs early enough that you might suppose that it was there at the time of migration. All these happens together, yet, of course, you don't know whether it happens due to recent infection or to reactivation disease. But there are other elements to think that reactivation is really important. These are molecular studies. When you type and cluster strains from immigrants, then you see that they are sporadic rather than clustered in large proportion. And this is further, although indirect evidence that reactivation is really important. So then we need to get into the management algorithm if you want to evaluate effectiveness. And we know that the crucial points are testing, and we have 3 options there: TST, IGRA, or sequential. What is recommended by the WHO is that is either TST or IGRA without any preference one from the other. And then there is the evaluation process to be sure that they don't have active tuberculosis before preventive therapy. This is done usually by chest X-ray, is a requirement. But you also need clinical evaluation, liver function test before starting usually. And then finally you have treatment options, and you have 5 treatment options. To just a quick look why the WHO says that TST and IGRA are exactly the same. And here the measurement was on positive predictive value of the 2 type of tests. And this was available in 1 single study, specifically on asylum seekers in Norway. And you see that the positive predictive value was the same with completely overlapping confidence intervals. Then what about the sequential approach using TST and IGRA? The WHO didn't have a look at this approach, so there is no recommendation, but it makes sense. This means you test everybody with a TST, and then you test the positive one with an IGRA, and then you just treat those who are double positive. And the advantage here is that you decrease the number of those who require testing with IGRA, which is a costly test, and you also limit the number of those who need to be treated compared to what you would do if you only use TST. Of course, it's more logistically complicated, and data on cost effectiveness are discordant. Coming to treatment recommendations, we know we have different options, and we can pick up again. The WHO says they are equivalent, and the choice should be done based on other criteria, which could also be criteria specific to a given risk populations, but there were no subgroup analysis to tell us whether in immigrants one specific treatment regimen is better compared to the other. And I want to bring your attention that there might be differences which are really linked to the population group you belong. These are data from a communication at CROI of 2015 concerning the I-ADHERE study. They were trying to demonstrate, and they did, that self-administered weekly rifampicin and isoniazid is not inferior compared to the DOT administration, which is the standard. So in the US population, you know that with a minimal loss in completion rate, you can use self-administered rifampicin and isoniazid. Then when you do what happened to the cumulative data also from sites outside the US, then it's not demonstrated anymore because the line is crossing the limit of inferiority. And this was due specifically to what happened to the site in South Africa. You see that if, as an average, the completion rate of self-administered regimen was 74%, in Africa was 39%. So you understand, definitely there might be reasons of infrastructure, but also cultural reasons might impact. So we take and translate results that sometimes we should not. The cascade of LTBI care, just to bring your attention to 2 points, there are a number of steps that can bring you down from what you intend to screen and treat to what you effectively treat. And that, contrary to what we were thinking till recently, the major loss are not after starting treatment, but in bringing people to treatment. And if you talk about effectiveness or cost effectiveness, you're not interested in any single step. You are interested in the full scale of steps. And demonstrating difference in one single step means nothing, because if you have a block in the previous step, then your advantage in the following steps will have no impact, basically. So there are big problems in dealing with effectiveness. And just to show you, when you want to understand usually what happens in reality, we ask ourselves using the PICO, posing a PICO question, the piece for the population. Big problems. Immigrants are a very heterogeneous population, and you cannot just pull all them together or generalize findings. Then the intervention, just remind you that all the elements of the cascade are important, taken together, and the outcome is the final outcome, is not one of the step of the outcome. Comparator, we don't have such study because the comparator of an intervention should be represented by unscreened immigrants, and usually these studies are not available. And finally, the outcome would be most probably incident TB cases, and that's also usually not the outcome that we see in the studies. But going to what is available, Andreas Sandgren, working for ECDC, produced this nice review published this year, but performed 1 year ago. And they measure completion rates of LTBI in many populations, and here I just report you the immigrants to show how large is the range for the initiation rate. Studies were 4, or for completion rates, studies were 9. And a meta-analysis could not be done because the variability between the studies was too wide. And then coming from the same type of systematic analysis published in the same issue of the journal by Sturman, then what are the factors determining completion rates of treatment? And what they found that, yes, it is generally true that if you shorten the treatment regimen, you then accomplish higher completion rate. This is true for almost every population groups, but including immigrants. We have one randomized controlled trial in immigrants showing this. But then there is another randomized controlled trial that we did almost 15 years ago, which shows the opposite. And the reasons here is that we were using the short regimen under DOT conditions, asking immigrants to come to the clinic, and it didn't work at all. So even shortening alone is not enough. Considering other interventions in immigrants, there are no randomized controlled trials, but there are observational studies, and basically all of them show an advantage by using, let's say, culturally sensitive approach and education when you want to treat and have high completion rates in immigrants. When you go to cost effectiveness, you have even more problems, because then you have problems in the mode of analysis. You can express it as cost effectiveness of cost utility. There you cost how much you pay for any TB case averted or for any quality gained of year of life with your intervention. So this is your gain, how much does it cost, and you can compare to such benchmarks. You can even use the cost-benefit analysis, where you compare directly in monetary units cost and benefits, and you say what is heavier. You have problems in the perspective. It usually is public health care, but can be societal, can even be third-payer perspective. And then finally, the majority of available studies deal with direct cost, and indirect cost are not covered, and is a very important issue. So what we know about cost effectiveness: one systematic review on cost effectiveness that was actually a scoping review published by Lorenzo Zammarchi 1 year ago. They included 9 studies, and they found that in 7, testing and treatment of LTBI in immigrants was cost effective, and in the remainder it was not. And what emerged interesting in their analysis is that one of the elements which had higher importance is the way you screen, and using IGRAS was more cost effective than TST. And then Enrico Girardi, who is here, and thanks for allowing me to show this, is just finalizing and submitting a more recent systematic review. But basically, if you that systematic review covers any population group, but if you deal with immigrants, and there are studies on immigrants, again, we have 9 studies, and it finds that 8 out of 9 show savings or have a favorable incremental cost, provided that you select your immigrants coming from high incidence countries. Just to show you what are the problems you make in cost effectiveness analysis, the cost of any single element, the screening test, drugs, how much you value a TB case prevented, have huge variabilities according to the settings where you measure them. So just to remind you that because of such uncertainties, some trial and interventions are ongoing. I want to just mention here the eDetect studies, and many of the people here belong to these European-funded studies. There is one more package whose scope is to check whether how it's possible to reduce TB prevalence in asylum seekers by screening them for disease, but also for infection. My conclusion would be the data on effectiveness in migrant population are scanty, so we need to take what we have for other populations in terms of screening, in terms of testing, in terms of treatment, and apply them to immigrant population, and this is not always properly. And concerning cost effectiveness determinants, they are so variable that with whatever study you will find in the literature will not be applicable to your situation. And what we need there is validated models that you feed with your own local data with variables that you have there, and then it will generate an estimate for your settings. Thank you very much for your attention.
Thank you very much, Alberto. Also, being within the time. All speakers have 20 minutes because the second topic is not coming up. And I would ask speakers if you can stay within this 20 minutes. We can also have some additional questions. I propose that we continue for the second speaker, and this will be introduced by Punan.
Thank you. So it's a pleasure now to introduce Ms. Marieke van der. She is the head of the head of the TB disease program at ECDC. She's responsible for the scientific and technical work of ECDC on TB surveillance, diagnosis, guidance development, and country support. And she'll share latest developments with regard to the guidance on programmatic management of LTBI from the ECDC perspective.
Thank you, Bonan. I had a nice first slide with my no conflict of interest, but I see that we don't have it. So, but just to say, I have no conflict of interest. I was asked to talk to you about guidance on programmatic management of latent TB infection, which is a guidance document that ECDC is currently working on. And in the end, I will also say something about the applicability of this guidance document for TB control in migrants. But before going to the topic, I would like to take this opportunity to show you one slide about the European Union, because this is a global conference, so I do not know whether you're all aware of the TB situation in the European Union. And therefore this slide, it shows you that in 2014 we had 58,000 TB cases reported by 29 European Union and European Economic Area countries. Unfortunately, Italy did not report in 2014. This gives us a TB notification rate of 13 per 100,000. And in 2014, we had 18 European Union countries that reported less than 10 TB cases per 100,000 population, which means that they are in the TB elimination phase. I also want to point out to you that the diversity of TB notification rates is quite large in the EU, with Iceland reporting 2.5 TB cases per 100,000 population, and Romania reporting more than 30 times more, about 80 per 100,000. If we would look at the percentage of TB cases in individuals of foreign origin, then the countries that are yellow in this graph would be red in the other map, because the countries with most countries with a low notification rate have a high percentage of their TB cases in migrants. And for example, Sweden, Norway and Malta report more than 90% of their TB cases in individuals of foreign origin. And overall there are 13 EU countries that report more than 50% of their TB cases in individuals of foreign origin. I already mentioned the word TB elimination, and we understand TB to be eliminated as a public health problem if there's less than one TB case per 1 million population. And here I did the forecasting for the European Union. In the last years, we've seen a decrease of the TB notification rate of 5 to 6%. So if I would extrapolate that, then we would reach TB elimination by the year 2092. Which is a bit late. So assume that we would want to reach it by 2050. That would mean that we need to double the decrease in TB notification rate. So that would also mean that we need to do additional actions. And that has been acknowledged in this document, as was already shown by Alberto, that additional priority actions need to be done if we want to go to TB elimination in countries that are now already in the pre-elimination phase. I especially want to point out number 4 of these priority action areas, which states that we need to undertake screening for active TB, but also for latent TB in TB contacts and selected high-risk groups, and provide appropriate treatment. So, this is one of the reasons that ECDC set out to develop a guidance document on programmatic management of latent TB infection. And with this slide, I want to go with you through the process that we use for that. We started with convening an expert meeting, and we asked the experts to tell us what would be the areas, the components that need to be included in a guidance document on latent TB control in the European Union. Thereafter, we initiated systematic reviews to collect the evidence base for the guidance document. That was followed by a period where we did mathematical modeling and cost-effectiveness studies. Then there will be an expert panel meeting where experts will discuss the findings, so the evidence base coming from the systematic reviews and the evidence base coming from the mathematical modeling and the cost effectiveness studies. And finally, the guidance document will be developed. So if we look at the first step, the expert meeting, then the expert, and we had in that expert meeting, we had people from our stakeholder organizations, but also at least one expert from each of the 30 EU member states and European Economic Area member states. And these experts identified 4 key areas where we would need to say something about in the guidance document. One was obviously diagnostic tests for latent TB, so what diagnostic tests are recommended according to the evidence. An area is preventive treatment regimens. What are the most effective preventive treatment regimens, and preferably are there differences for most effective regimens depending on the risk group. Then the risk group, which risk groups to screen for latent TB infection, and what are interventions that can improve the risk group screening and also the treatment of risk groups. And then in the end, they thought it very important to see whether latent TB control can be combined with other health programs. This guidance was developed by WHO and already shown. It was launched in 2015. And at that time, 14 systematic reviews were done, and they were done both for the WHO guidance document and for the ECDC guidance. Since it has been some time, we've decided to update 2 of the systematic reviews, and the one on the diagnostic tests has been updated, and the one on the best treatment options for latent TB infection have been updated. Then I come to the results of the mathematical modeling and the cost effectiveness studies. It's a rather complicated graph, so I'm going to walk you through. First, I have to say that these are the results of the societal perspective. We also looked at the healthcare perspective, but these are the results of societal perspective, and they're a little bit different, and I'll say some words about where they differ. You see 4 types of, or actually 5 types of group that can be screened. Migrants at entries, and then prisoners, either migrant prisoners or all prisoners, and behavioral-related high-risk groups, or all risk groups, and that would entail the migrants, prisoners, and behavioral-related high-risk groups. The behavioral-related high-risk groups can be screened either annually or tri-annually. Then we did the cost-effectiveness studies, or we were able to do it for 4 countries that could provide data, and those were the Netherlands, Czech Republic, Portugal, and Spain. And I will now focus my explanation on the Netherlands, which is in the left upper corner, sorry. On the x-axis, you see the incremental costs, and on the y-axis, you see the incremental QALYs gained. And it's incremental because it's compared to a baseline scenario. And for the Netherlands, the baseline scenario would be chest X-ray screening of all migrants at entry in the Netherlands, and chest X-ray screening of migrants and behavioral-related high-risk groups when they enter a prison. So that's the baseline, and then all the other scenarios are compared to this baseline. You also see a black line, and the black line connects the most cost-effective strategies. So if you then look at the graph of the Netherlands, you see that screening by TST followed by IGRA, and then doing that for prisoners would be, in this case, actually even a cost-saving strategy because it gives you negative costs. The next most cost-effective strategy would be screening of behavioral-related high-risk groups every 3 years using IGRA. Thereafter, it's the annual screening of behavioral high-risk groups, also by IGRA, and then you come to screening of all risk groups, and basically all 3 test strategies could be used for that. If we compare the results of the societal perspective with the healthcare perspective, then one of the main differences is that if you look at the healthcare perspective, testing with TST followed by IGRA is most cost effective, whereas if you look from a societal perspective, just using the IGRA is most cost effective, which of course has to do with the time that a patient needs to spend to come back for the result for the TST. Yes. One thing that you can also see from these graphs is that actually screening of migrants with whatever testing strategy does not seem to be very cost effective in these 4 countries. It's the red dots, so here and there and there. So it's low. It doesn't give you a lot of QALYs gains compared to the baseline scenario. But in most of the countries, the baseline scenario includes a chest X-ray screening of migrants at entry. So that has to do with the results, of course. So the boxes, the activities in bold have been completed. We are now going towards the expert panel, which will actually be on the 7th and the 8th of November. And then the plan is to finish the guidance document somewhere in the first half of 2017. So now I come to the question that was raised, is this guidance also applicable to migrants? And then I have to say that actually ECDC is doing several guidance documents, but 2 are relevant for this discussion. We're doing this guidance document on the programmatic management of latent TB infection. But at the same time, we're doing a guidance document on the prevention of infectious diseases among newly arrived migrants in the European Union. So in the one that we discussed this afternoon, the guidance on programmatic management of latent TB infection, will cover the whole population, including migrants, but it's completely focused on latent TB infection. Whereas our other guidance document, the guidance on prevention of infectious diseases among newly arrived migrants in the European Union and the European Economic Area, will cover several infectious diseases, including HIV and hepatitis, but this one will only be focused on migrants. So we do cover migrants, Bonam, and in both documents. I'd say to Ponan because she specifically asked the question. To finish, I want to acknowledge the people who worked on what I presented, and that's the Erasmus University and Radboud UMC who worked on the mathematical modeling and the cost-effectiveness studies. Palace Health Research and Consultancy collected all the evidence base that will be discussed in the panel in 2 weeks, and then my colleagues from ECDC also worked hard on this project. Thank you.
Thank you, Mariake. We do have time for 1 or 2 questions from the floor that may be specific to this presentation. Okay, in that case, we'll move on to the next presentation. We will have some time towards the end of the session for discussion.
And I can be short because Knut is already there. Knut Lönnroth is working with the Global TB program with WHO, and he's a professor at social medicine at the Department of Public Health Sciences at the Karolinska Institute in Sweden, in Stockholm. The floor is yours, Knut.
Thank you, Gerard. Good afternoon, everyone. A question posed in the title of this symposium is, can we move from controversy to consensus? Sometimes I have a feeling we also need to move from some confusion to clarity. For example, whether we're talking about clinical relevance or public health impact. Now, regardless, the path towards clarity and potential consensus needs to go through better evidence, as you've heard in the 2 previous presentations. Now, research, including trials, is a part of that, but another part of that, getting the data that we need, is to use surveillance data on LTBI, which are very scanty and not collected in most countries, or potentially to tap into existing medical records and registers that may have not been created for the purpose of monitoring LTBI, but maybe could be useful. Now, this presentation is about data sources. So anyone expecting me to help you move to clarity or consensus based on data will be disappointed, because I'm not going to present any data. I will talk about the potential to get data from a selected number of countries. And this is part of this eDetect project that Alberto was mentioning. It's another work package which is about attempts to try to map out, extract, pool, compare data across a number of countries. Now, before coming to that specific project, I'll just put it in the context a bit. Here is a selected number of the EU countries that we have looked at, and they share some common TB epidemiology. This is what Marika was talking about. In those countries you see on the map here, a big proportion of the cases are foreign-born, up to 90%, as Marika said, in, for example, Sweden and Norway. And the rates, which are the red bars, are much, much higher than in the foreign-born, much higher than in the native population, up to 50 times higher, actually, in Norway and in Sweden. Now, as you've heard, a large proportion of these cases are due to reactivation of latent TB contracted in the home country, or at least outside the host country. And therefore, potentially, one way to reduce the rates in the red bars is to screen for and manage latent TB in the foreign-born. So, what are countries actually doing? Well, this is a quick mapping of the state of policies with regards to latent TB screening in migrants in those countries. It's a busy slide, and I'm not going to take you through all the details. The main message is policies are very different. So, for example, different groups of migrants, asylum seekers, refugees are being targeted, different age cutoffs. And if you look at the third column, in terms of TB incidence rate in the home country, we see Netherlands is using a cutoff of 50 per 100,000, Sweden 100, England 150, and Norway more than 200. One country uses compulsory screening. The others that are doing any screening, it's voluntary. And then there are different also indications for treatment, either all people that are screened positive or some additional considerations with regards to risk groups or age variables. So a lot of differences. And a part of this is due to different preferences and values and competing needs. And certainly some political factors play out here as well. But I think the underlying issue is lack of good evidence to show whether to do it or not, and what the focus should be. What are the risk groups that should be targeted? And then, of course, also how to do the screening and what is the best treatment strategy. So now, all the questions, and Alberto did an excellent overview of all the things that we need to understand. I've made an attempt to schematically capture some of the unknowns, some of the things that we need to have better data on. So let this yellow circle be, for example, all foreign-born from TB endemic countries. So a small fraction will have active TB on arrival. For that, we have pretty good data from countries that are doing screening for active TB. Now, the big circle there is a fraction of all these people will have latent TB. Here we need better data, both for the whole group and then for each subcategory of migrants. What is actually the prevalence of latent TB? And also importantly, within that group, a certain fraction of the people with latent TB have risk factors for progression, high risk for progression. And we need better data to understand how big that group is. Next is we need to understand better, as you heard, about the reactivation rate, not only on average, but for all the different groups, including different types of risk factors. Now, this is not real data. It's just an example of how it probably plays out. So if you have the high-risk group, they will contribute, as a significant part of the active cases that will arise. There will be a small fraction of people with active TB on arrival. There will be some infection after arrival. Probably the largest part, the blue part out here, is reactivation of those people that do not belong to the highest risk groups. So as the prevention paradox often tells us in public health, most of the prevention possibilities lies in reducing the risk in those with a moderate risk increase. And if you target only those with the highest risk, you will have some impact, but not be able to prevent the majority of the cases. So one question here is, can we expand the risk groups eligible for LTBI screening and treatment? Where is the cutoff for the risk and benefit ratio? Where is the cutoff for cost effectiveness and cost benefit? These are the unknowns that we need to understand better in order to realize the potential of having a real prevention impact from latent TB screening. If you put it as specific questions, then what is the number needed to screen to detect one LTBI case? In other words, what is the prevalence of LTBI? What is the number you need to treat to prevent one active TB case? That's related to the reactivation rate. What is the number needed to harm, which is related to adverse drug reaction rates? And in the end of the day, what's the proportion of active TB that can be prevented? If we translate it even to even more specific questions that we are trying to address within this eDetect project, well, we have one specific question, which is about the prevalence of LTBI. Actually, we need much better data on that, also disaggregated by country of origin and age and sex and by risk groups. So I highlighted that in red because this is what we hope to obtain from this project over the next year or so. And then there are a set of other questions that will maybe possible to obtain from some of the settings. So reactivation rates is trickier, will take a long time and requires a big sample. There are some operational or implementation or programmatic issues, if you like what is the proportion that are actually screened, what's the uptake, and then of those that are screened positive, how many are referred, evaluated, started on treatment, completing treatment, and what are the operational challenges? So there are systematic systems and patient factors playing out there. And in the end of the day, what does it all cost, and what's the cost effectiveness? As you heard from Alberto, critical things that we need to understand better. Now, coming to the actual survey, actually I wouldn't call it survey, it's more like a mapping exercise of some of these countries to understand what the potentials to getting data. So we have done this for 7 countries so far. We may add more countries if there is an interest to join this project. So in the end of the day, it's about creating this multi-country database with LTBI data, and along the way also see if there are ways to improve the systems to gather data. Now, part of this is mapping out then what are the potential sources of data available today. Another busy slide, and again I won't take you through all the details. Let me just highlight what we have seen as the potential data sources. Let's start with reporting and notification data. There is very little formal notification by law. Actually, there is none, though there's an attempt now in England to go to more compulsory reporting of latent TB cases. So here we're talking about the numerator data. There's a number of people with positive test results or diagnosed with latent TB. Although compulsory in England, as I understand, means you will not be reimbursed for the treatment, and Dominic Zenner will come and shout at you if you don't do it. But it's not by law, really. So that's one source that is possible, but it's a soft one. ICD registry, can you use that? Well, if the ICD codes used are standardized and you can extract them. Maybe more promising is electronic medical records. So if they are standardized with some variables that you can extract in an easy way so you don't have to do full record reviews, that is a potential that may be possible in some countries. Lab records, yes, you can get, at least for IGRA, you can get potentially from some countries, but it's, as you can see, it doesn't look very promising. And finally, you can get treatment data from the treatment centers, potentially in some places. So this is numerator data. I should also mention, when we ask this for a country, it becomes very tricky because different parts of a country could be very decentralized, and you have very different answers if you ask the different regions of the same country. What about the denominator data? Well, same picture, a lot of variability, reporting numbers of people. So now we're talking about the number that have been screened for latent TB. Well, possibly to get from some kind of formal reporting system. Again, medical records, if they are, as I said, standardized and extractable, possibly. Same with the laboratory records. Now, if we look at all the countries across here, if we ask the question, what is it possible to have at least one source of information from which you can get at least data from some parts of the country? We have yes for all countries except for Italy, but Alberto is working under this eDetect project with colleagues to set up, at least for some parts of the country, so we can get LTBI. This is not data. This is not to say it's all possible everywhere, but there are some potential at least in all the other countries. I'll take you now very quickly through 3 case studies, starting with my home country, Sweden. The rationale is up there in the slide in the upper right corner. I don't need to explain it to you. It's quite evident that this is a critical issue for TB control in Sweden. The policy is to invite all asylum seekers for screening. So it's invitation, it's all voluntary, if they have been less than 2 years in the country. It's done in primary health care as part of a health examination that people are invited to. IGRA and TST are used, and if it's positive, then an X-ray So this is also screening for active TB, in fact. Now, if a person is suspected to have latent TB and there is a treatment indication, meaning risk factor, contact, or age under 35 or 20, depending on the region, then there should be a referral to the specialist services for treatment consideration. So that's the sort of the policy. Now, this has been in place for many years, but in fact, it has not been evaluated yet. So there are a number of unknowns. These are the same kind of questions that I put on Alberto before, so I'm not going to read them out to you. In fact, there's a need to look at the data in more detail. So rather than setting up a big research question with original data collection, we're now exploring whether you can use the available data sources. One is possibly using the notification system. There is actually a function that you can notify anything you like, but it's not used in practice. So the other is ICD registry. Well, it could be used, possibly. There are attempts to standardize the ICD codes, but even so, it would only give you the numerator data and not the denominator of how many people were screened. Lab registry data, possible in some settings, some regions that have a centralized IGRA testing, but the most promising one is to use electronic records in places where it's standardized. So I'll now give you a sub-case study of Stockholm County, which is the biggest one with a large number of TB cases and migrants. The potential here is that the same electronic records are used throughout primary healthcare and the specialist services that are concerned. So in the primary healthcare settings where these health examinations are done for migrants, there is a specific module with some standardized variables. So you can get TST or IGRA results, you can get country of origin, age and sex. And then you can get a lot more, but it's all in free text, so it's quite messy to extract that data. From specialist care records, and they're interlinkable, we hope to be able to get diagnosis, clinical data, and treatment initiation, maybe completion as well. All this you can extract centrally from the eHealth unit at the Stockholm County. So possible data flow, and we're just about to start the data collection. Actually, another data source is from the Migration Authority that has the number of asylum seekers coming, in this case to Stockholm County. That information actually goes to the primary healthcare, who then makes the invitation of the asylum seekers to come for the screening. So the data on the screening, how many screened and screening outcomes, can be extracted from this central eHealth unit. That can also extract data from the specialist clinics. And all that then, together with the denominator of how many asylum seekers should be screened, can be fed into what we're now creating, a latent TB screening database. Possibly in the future also linkable to the National TB Register of active cases. So what we hope to capture is the cascade that Alberto showed you data from one setting. So from the Migration Authority, number of asylum seekers and how many should be screened, primary healthcare number of screened and screened positive, from the specialist care, how many treated, how many put on treatment, and hopefully also someday the link to the number of cases reactivated. That was case study number one, an attempt to extract from existing registers not designed for TB surveillance. Now the next two case studies are from England and from Netherlands. I'll do my best. If I say the wrong things, we have the people responsible in the room who can sort it out for you. So England, not UK, but England, Public Health England is driving this. So we have the eligibility criteria I already showed you, principal migrants from countries with more than 150 per 100,000, aged between 16 and 35. It is primary care based and the screening, and then referral to specialist services, pretty much along the lines of the Swedish case. This is all a national initiative. There are protocols. It's funded, and there is a specific monitoring system that has been set up for the purpose of monitoring this. This is the screening algorithm. I'm not going to take you through the details. The important thing is, I think for this purpose, is what happens up here. It's people, new registrations with a GP, or if you're already registered and you can be searched in the files to be identified as an immigrant that fulfill their criteria, you can be invited to come for this screening. Now, there are a number of indicators that have been defined and will be monitored, and they're listed here. It's pretty much, again, the screening and treatment cascade that you now heard a couple of times about. So the data capture is through a web-based reporting system that the GPs are supposed to fill in, and if I understand correctly, also the specialist services need to fill their part of this. And then it all supposed to flow together, so primary care data, secondary care data, into Public Health England database where it all will be analyzed, and made sense of, and under eDetect, hopefully also shared then into an international database. 2 slides on Netherlands. Netherlands changed a bit the strategy for TB screening, introducing LTBI screening in immigrants less than 18 years. And there are 2 entry points. One is for asylum seekers, and that is done in a reception center. I don't know if it's one or several, but anyway, it's so pretty much centralized. And for other immigrants, it happens in municipal public health services that are scattered around the country. Very brief summary of this. It's designed, again, a system designed to capture the data specifically for latent TB screening for immigrants from the public health centers, asylum seekers from the reception center, flowing into a specifically designed client information system that will feed into a latent TB screening database linked to the National TB and LTBI register. And then, as you see at the end, we will come to Gerard in KNCV, who will make sense of the data. And there is already 100,000 plus migrant screening data, as I understand. We can discuss that later.
Maybe just to add in on that one, so this is how the screening for active TB is now entered, and that is the 100,000, but for latent infection we're just starting, as you mentioned.
Okay. To conclude, we have 2 countries with sort of designed systems to capture LTBI screening data, but it's not much available from other countries. Now, some countries are exploring, Sweden among others, to use existing data sources and to make sense of the data. Now, there is this question, should countries actually set up specific M&E for latent TB screening? And I think eDetect project share this vision that we need to do it in order to help answer the questions that we have. And if we find in the end of the day that it makes sense to screen for latent TB, at least in some groups of migrants, and become a public health intervention, then certainly we need to have a surveillance system to monitor how that goes. So we need to have that data at least for the first decision point. And what the eDetect will do then is to try to help both the processes of establishing data and then pool the data, compare between countries, and help to make sense of it. And I'll finish just with a slide on the next steps under this eDetect project. So we will complete the inventory or mapping of countries, including subnational information, because that is going to be critical. Then develop a protocol for data sharing with different levels of complexity of the data depending on what is available. And then to populate this multi-country data set and do the analysis and feed it back. And then 5 years from now, we'll have a review process to see what we have learned from all this, feeding into also original research, trials, etc. And with that, on behalf of the eDetect team, I thank you for your attention.
So thank you very much. There's time for some questions, and specifically I would ask somebody from the non-EU countries to maybe share an experience of screening latent infection in migrants in other parts of the world, since this is the World TB Conference. Is there somebody from other countries outside the European Union who could share? Paul might share a little bit from Australia in the next session, but there's somebody here, yeah?
Eckhard Alpeter from Switzerland. We had latent TB infection. Well, till 2006 we did LTBI screening in Switzerland, and only 50% of the patients got a treatment, and we never could prove that they finished their treatment, because migrants are very fluctuant population, and I think these issues you should consider as well in other programs.
So, yeah, thank you for sharing. You know that in a couple of years' time we also have to say that the UK is not part of the EU countries, so we have more experience from non-EU. Is there somebody else? I see Howard and Joe from Canada.
Here.
Middle of the, yeah, you're sitting in the middle of the room, Howard, yeah. Maybe you can throw or you can speak very loud.
I can give you that. Can you pass it on for me, please?
Thank you very much. So similar to many of the EU countries, Canada is a low incidence TB country. The majority of our TB cases are foreign-born, about 2/3. So similar issues. In terms of screening, right now for migrants, in terms of our legislation and so on, the only screening we do is with a chest X-ray to rule out active TB. So anyone with active TB is obviously not allowed into the country until they show proof of treatment. We've been discussing, debating when and where best to screen migrants for latent TB, because we recognize with the pool of migrants coming in, the majority of the cases activate within Canada within 5 years of arrival. So there is that opportunity, that window. But right now, the challenge is, as many may or may not know in Canada, we are a decentralized system in terms of being a federal state. And so there's no, quote, national TB program. We have 13 individual provinces and territories, each with their own issues and challenges. So, for example, in Canada, the 3 largest provinces that have the largest influx of immigrants also happen to have our 3 largest cities, would be British Columbia with Vancouver, Ontario with Toronto, and Quebec with Montreal. And those provinces are the ones in which we might maybe start doing a pilot project, seeing what we can do with our immigration department, with us as the public health agency, and with those provinces. Because besides that, in Canada, some of our northern territories, the issue isn't so much migrants, but still with our indigenous peoples and high rates of TB. So we are looking at it, and we recognize that there are multiple points within the so-called migration pathway that would be the ideal, maybe hopefully intervention point. But we look forward to some of the information data coming out of other countries, and as we forge our own way, hopefully we'll collaborate with the rest of you.
Okay, thank you, Howard, for that. One question here.
Well, let's look into some other parts of the world away from the advanced world.
Can you introduce yourself?
I'm from Kenya. So let's look into the eastern part of Africa and the Horn of Africa. So what I was listening is what we are doing here is country by country by country, and each individual country is coming out with a plan of doing the screening or not to do the screening or whatever their plans are. But we have other regions in the world where probably just one country cannot take up the whole load. It has to be done by a regional way. For example, in the eastern part of Africa, it's one of the highest population movement. And in this region of Africa, it's not only the migrants. When we talk about the migrants, it's not only the refugees, but it's a huge component of immigrants related to economic immigrants, lifestyle, nomadics, pastorals, refugees, and many other people who actually live across the border and keep on moving on a daily basis from one side of the border to the other side of the border. Now, it's very difficult in first place to really track how the population movement is actually going to take place. So first of all, it's very difficult to really recognize and to detect the TB in this population. Second is, we talked about in these presentations about the IGRA and TST testing or duplication of the testings. I would say that in many places, excepting for the X-rays, it's no other tests applicable or maybe available. So in those situations, we are really at a loss to really understand that what we can do in those situations, in those populations. So, I mean, it's a very tricky situation in other parts of the world to really detect and follow over the TB.
Thank you. I think very valid question, and maybe you can comment on that one, Knut, maybe from WHO perspective too.
Well, yeah, I mean, it's up to the chairs, but we could talk about global
brief
interactive TB.
Just
But I think the point of this symposium, and I think we'll come back to that in the general discussion, is can we find consensus among countries with similar situations? So we're now mainly looking at low incidence countries where the infection rate is very low. A lot of it is reactivation of latent TB, and the dominant group is migrant from endemic countries. So it sort of sets the stage for a number of countries. Now, this was about Europe. You heard ECDC perspective, but there is also a global agenda for all countries that share similar epidemiology. And certainly that is also, WHO is developing guidelines, which is mainly for countries with a lower incidence. ECDC is developing. US has come out with that recently. I think that is what we would like to see is a movement towards some consensus for countries that share similar epidemiology. But I do think for screening for TB, as for many TB interventions, there needs to be a very clear thinking about the differences in epidemiological context. So adapt your strategies in relation to that. I think we'll come back to that later, no?
Can I make also a comment? So just to clarify, chest X-ray is an acceptable, definitely, tool for screen for active disease, which is what would be important in a setting like Kenya. IGRAS or TST, which are intended to screen for LTBI, I don't think there is any recommendation. So don't think about screening a moving population with tests for infection. There are no recommendations for that, and basically this is WHO recommendations for that, and basically this is based on the fact that while detecting and treating infection in that context, probably the benefit that you gain is marginal, much less than what you get in countries where transmission is low, and the benefit is maybe lifelong of treating infection.
Thank you very much, Alberto. So we move on now to the next session. And in fact, this is a presentation, it's the last session, presentation of the working group on intergovernmental immigration and refugee health. And that means that we also have 3 presentations, starting with Paul Douglas, starting with Dominic Zinner from Public Health England. And I also already mentioned the other 2, or you might mention them, but it's Joanna Regan, pediatrician from CDC, and Paul Douglas from the Immigration and Border Protection Department in Australia.
Thank you very much, Gerard, and good afternoon, everyone. We are going to start this presentation by what we do at the moment, which is active TB screening, and then move on to all the possibilities that arise from, a unique position of screening a cohort of people, and what might arise from that, including latent TB screening. And so, in order to reflect what we are, which is part of the Immigration Refugee Health Working Group, which is basically a working group of 5 countries that are trying to align their policies and their services, and sometimes even the clinics, to try and get better at pre-entry screening. To kind of reflect that, we have 3 speakers. So we have not only myself from the UK, but Paul Douglas from Australia, and Johanna Regan from CDC from the US. So we are on the road, as you can see. This is TB screening is not the only thing that the IRWIC, as we call it, the Immigration and Refugee Health Working Group, is doing. There's many other diseases that they're screening, but the one thing that we all have in common, that we all screen for, is for active TB. And as I said before, we are trying to have best practice, find the best practice, and try and align along those best practice things. But you can see that there is a long way going, and we're trying to worry about malaria and vaccine-preventable diseases and all sorts of things. But at the moment, we have been focusing on TB. The screening algorithms for active TB are relatively simple and relatively streamlined, actually, as you can see. So it's basically a very sensitive or a relatively sensitive test, a chest X-ray, followed by a highly specific test like a sputum smear and culture. And basically, most countries have now agreed on this kind of algorithm. In fact, you can see the US algorithm here and the UK algorithm there, and they look a little bit, it's a slightly busy slide, but trust me, they are very, very similar. So that's that. And what we also started to do is to look across these different countries and have a look at our experiences, what we can learn from that. So here you can see 2014 data, and you can see rates per 100,000, Australia, Canada, UK, and USA. Have a look at the second line, which basically shows you that in 2014 alone, just under 3,000 cases were found pre-entry, active TB cases found pre-entry and treated by those 4 countries together. And we're trying to look at these kind of figures and understand them better. In fact, now we're delving even deeper than this, and we're having a project looking into the India data, our experiences in the 5 countries, and trying to understand why we're screening to different thresholds. So there are comparable rates, but actually the US does much better than anyone else here, and why is that? And so it might have to do with a mix of migrants, it might have to do with the type of people that are migrating, it might have to do with different screening practices. The top 5 countries you can see here in terms of the rate so there's the Philippines, PNG, Cambodia, Indonesia, Vietnam. For Australia, for example, for the UK it's Philippines, Nepal, China, India, and Thailand. Similar sort of countries you can see. And a couple of slides on showing you that indeed we do have some impact onto the host country epidemiology. What you can see here is the number of cases, pulmonary TB cases, and you see in the green, this is the countries diagnosed pre-entry. Good news is going up, and this ends at 2014. There's another bar in 2015, which is even higher. And the TB cases identified in the country, which within 1 year of entry. And just to reassure you that pre-entry screening it does what's on the tin. It screens out the prevalent cases, the cases that are there at the point of screening. And that's good news. We're basically doing what we said we should be doing. This is the US data, which looks a bit more complex, but it's actually a very similar slide. And so this is the domestic case notification. And what I need to say is that in 2007, or from 2007 onwards, I'm looking at Joanna to see whether I'm right, but I think they introduced sputum culture confirmation increasingly. And what you can see here is the number of cases that was screened, found pre-entry, increasing quite rapidly. And the beauty is that the figure here approximates the figure here. So basically, the incidence in the country goes down as the incidence overseas, so as the yield overseas increases. And I shall hand over to Joanna. So I'll stop with the pre-entry thing, and we'll move on to the opportunities.
Thank you so much. So in 2012, the earwig countries agreed to coordinate a standardized approach to provide high-quality TB screening and treatment pre-departure. And this slide illustrates the various steps of that, from the high-level TB strategy to the country-level finding the diagnostic centers and qualifying those. So this slide I very much like. So I'm actually new to Immigration and Refugee Health on Drew Posey's team, and I'm filling in for him today. He unfortunately couldn't be here. But this is my favorite slide because it shows travel. And as someone mentioned in the audience earlier, these are the different aspects we need to address in our work with migrants. And you will notice the travel is a two-way street. So my previous job was working in a group called Quarantine, and I worked with doing contact investigations involving people who had flown with infectious TB on an airplane internationally. So we were in charge of notifying people within the US and, of course, in other countries, because these people go on to expose others. And what was fascinating to me is how truly mobile the migrant population is. So when I came to Immigrant and Refugee Health, I looked back at the old data set of people with TB who had traveled recently. And I hadn't really looked at their visa status in the past because that wasn't the function of my job. But looking at it with new eyes, it was fascinating to see how many people were short-time visa holders, how many people were actual immigrants. And the immigrants were that I was seeing just anecdotally. For example, the first case I found was a woman who had been a US citizen for 17 years, and during that 17 years, she had flown back to her home country of the Philippines every year. And the flight where she had most recently flown while infectious with TB was not to the Philippines, it was actually to China to visit others of her family who had also immigrated to another country. So you think of what a challenge it is to stay in contact with this population, but also all of the potential exposures that can occur when TB is not well controlled. So it's important to think about the global good. So of course, in addressing this population, the shorter the time period is that people are infectious, the less transmission will occur, and that potentially serves all of us throughout the world. And this is an interesting concept, I'm not sure if others have heard of it, called enlightened self-interest. And this is a study by Schwartzman et al., which very clearly illustrates this concept. And this is using data from Mexico and the US. So as you can see on the curve, when you use a chest x-ray and skin testing, the cost of TB screening goes up for the US when they're screening immigrants. However, if you actually focus on improving DOT within Mexico and the radiographic screening, the cost goes down and turns into savings. So what this really illustrates is sometimes the best way to protect yourself is to help others. And that is our whole concept of capacity building. So definitely in this work, it's important for us to think of not only the patient themselves and the patient-centered care, but all the other factors in the other country where the person is originating. And so now some concrete examples of things Earwig has done before my time to improve and build capacity. So the first one is an example from the Dominican Republic, in which the panel physicians there, they have an excellent panel site, and the panel physicians have gone on to actually train the NTP staff about diagnostics, new techniques and treatment, etc. Also, laboratory capacity building, so in multiple high burden countries, capacity has been improved by introducing liquid culture to many high burden countries, as well as second line DST testing. And then IOM has done multiple things, one of which is to win a TB Reach Award involving MDR TB capacity building in Ethiopia and Thailand, and in Nepal providing culture and DOT to anyone who needs it within the camp, and many other examples that we could provide. But at that, I will turn it over to Paul.
Thank you. My apologies for the Trinity presentation, but we felt it was important to show that countries can work together. We've got 5 countries who work very effectively together, and we can actually talk together. And it's more than just what we do for ourselves then, as you can see demonstrated through here. It's actually shows that we can benefit countries who we're doing the screening in. I think what's important to note here is also that this is pre-migration, and I suppose I'm going to raise the most contentious thing about, we've talked about LTBI screening and migrants in countries after they arrive. We're going to now delve into the area of LTBI screening pre-migration and where that sits as we go forward. So we know in any TB control program, telling all the converted in the room here that we can stop the infection by actually vaccinating people if we ever find a decent vaccine. We can try and prevent the infection becoming a disease through LTBI treatment. We can do active case screening. We can, when we identify cases, treat the case, or we can isolate that case to stop them spreading disease. So they're the basics of an LTBI process. So what does that mean about pre-migration screening then for LTBI? We know that, as we pointed there before, improving the diagnosis and treatment and early case finding actually doesn't help low incident countries. In Australia, for instance, we have our TB rate in the Australian-born population is 0.6 per 100,000, or 6 per million. So we're already almost at the elimination rate in the Australian-born population. 90% of our TB comes in our overseas-born population. So focusing on continuing to do just pre-migration screening isn't going to stop new cases turning up because most of our TB is going to be coming through reactivation of that TB. So where we then need to go is look at what we're calling the second wave of TB control is through the diagnosis and treatment, and we've seen these documents and all the rest before, so I'm not going to dwell on those as we go forward. So I want to talk about where we then go as we talk about the evolution of TB control and where this fits within a pre-migration setting. So we all know about the focus on the dots back in the 90s, looking at the smear positivity, making sure we got the diagnosis right, and again, the cost effectiveness of this treatment. And we still will continue to talk about the cost effectiveness, as we heard right from the very first speaker here. The second thing is the second strategy was talking about the Stop TB strategy, which is enhancing case detection, and now we're on to the end of TB strategy, which is talking about moving from TB control to TB elimination. And it's not just about active case finding, as we do in a pre-migration setting, but it's also about how can we actually move on to LTBI strategy to actually reveal all that stuff that's sitting underneath. I really like this slide, and I don't know if anyone knows who Willie Sutton is, but he's a very famous bank robber in the USA. And I like to say this because with all the evidence there, when Willie Sutton was arrested, they asked him, why do you keep on robbing banks? You've been going back to banks time and time again, and you keep on getting arrested. And he said, well, that's where the money is. And that's for us, if we're ever going to beat TB, LTBI and the prevention of activation of treatment is where the money is. And particularly I'm talking about low-income countries here. So I want to talk about where we're at. In some respects, for migration screening countries, we didn't start out doing latent TBI screening. We started doing screening for children to use this as a two-step strategy to actually exclude active TB. We didn't want to overdo screening radiology on kids. And so the US have been doing this now for 6 years. They've got quite good data sets. Australia's been doing it a bit more recently. And so what I'm just going to present very, very quickly is where we're at with some of this data. So this first study by Ebony Taylor, by Ebony Taylor, shows that the 4 years of data, I think it's from 2010 to 2014, talked about how many kids were screened offshore for latent TB infection by the USA, how many were decided they were diagnosed offshore. So in this study, 8,231 were diagnosed with latent TB infection offshore. 70% were successfully evaluated after arrival. Of those 70%, 57% were confirmed with having TB. They tended to retest with IGRA rather than TST offshore and found there was a very high over-diagnostic rate with TST. 68% were initiated with treatment of that original of the ones who turned up on shore and were confirmed, and only 30% completed treatment. We've got the more recent data by Sanju Wang from CDC. Again, shows similar sorts of things in a refugee population where 70% were confirmed on shore, 80% of these initiated treatment, and only 40% followed up on treatment. So the argument then comes to say, is this cost effective or not? More recent data is showing this. So this is from the last program year from USA, and the Australian data that we've started since we've started on from this process. So we'll talk about the USA first. So in last year's program, in 2015, they reported that they screened of all the kids that they screened, almost 6,000 of these children were diagnosed with LTBI. 95% of the US cohort use TST, with only a very small percent using IGRA. The Australian data is very different. We've only started this process in 2015. Whoops, don't know how that happened. Started in 2015. That was as a result of a study that was published in Australia by Ben Moraine and some others, which identified that of children who are developing TB, and I'm talking about children less than 11 years of age in Australia who developed TB, 65% of these were overseas born children, and more than 2/3 of them developed TB within the first 12 months of arrival, which showed that we weren't actually effectively excluding TB pre-migration. Different to the USA, about 50% of the tests in Australia are diagnosed through IGRA. What we're finding of that 23,000 children is that around about 4% of them had positive tests. IGRA was giving a positivity rate of about 3 times that of, TST was giving a positivity rate of 3 times that of IGRA. Of those positive tests that were further examined through chest x-ray, about 3% of those had abnormal chest x-rays, and didn't really seem to make, it's probably a little bit different with IGRA and TST, but the data's too early to say. And we've had 6 diagnoses confirmed of those with active TB prior to arrival. The additional thing with Australia is, though, that we have what's called a TB surveillance program or TB undertaking program. So every child who has a positive test is then referred to an onshore provider after arrival onshore for further follow-up and hopefully treatment. Now, we don't have that back-end data. We've got systems which are collecting that data, but we don't have that analysed yet as to how many are actually receiving treatment and have completed treatment. So if we go just my final slide in terms of the IRIG type data is that, so looking at the stuff that's happened from Australia, we've actually compared about what the positivity rates is depending on the incident rates of country of origin, and tried to make some sense of the data. And basically, to me, it didn't make much sense at all, although we're learning as we go. So the overall positivity rate basically says that if you're coming from a high incident country, you're much more likely to have a positive latent TBI test, 7% from greater than 300 per 100,000. Although as you get down to the others, they're pretty consistent with what's in there. If we do it by IGRA, if we do it by IGRA alone, we see that there's 3 times the rate when you're looking at that, and probably maybe something there. What we also find is there's an inconsistency in what we expect from the cohorts. So if we look at the high incident rates, so Pakistan, Papua New Guinea, Cambodia, we see only 1% of the cases there of children being screened are positive for latent TB, which doesn't seem to make much sense, but it may be the cohorts who are coming. And yet when we look through the data, we see that Russia, Ukraine, and Lithuania are all up around 11, 15, 17%. So again, it was quite surprising, some of this data that we're seeing as we move forward. So I suppose the question for us from here is where do we go from here? Do we start to do latent TB? Do we start to do latent TB screening for other cohorts before they arrive? If we do, who do we actually screen that in that situation? And should we be looking at treating people with positive latent TB tests before they arrive on shore, noting that it may delay travel by 3 months? So there are questions the group is actually grappling with at the moment, and quite happy to put it out there as a contentious comment to see if we can get consensus here this afternoon. So I'll just finish up there, and this is a slide that I got from Lee Reichman, but I think it sums up what we do quite well. Thank you.
Thank you very much. So we still have 8 minutes for the discussion, and I'd like to open the floor for the discussion. The title was controversy, we heard confusion, we heard consensus. I even wrote down some more words with a C. Collaboration was another issue. I'm particularly happy to see this last presentation. Big data is coming up. eDetect-TB is looking at big data, but we're talking now about 20,000 people screened for latent infection in a certain group. There was something in the presentation from Marika where we looked at cost effectiveness at migrant screening. And I can ask the first question to Paul. Did you also look at cost effectiveness of the screening of migrants between 2 and 14 years? Because that's one important issue, I think, to look at.
I think that's a very reasonable question. Australia doesn't screen between 2 to 14 years. That's USA, so you'll have to ask them about the 11 to 14 year age group. And from the 2 to 10 year age group, no, we didn't look at cost effectiveness whatsoever. From an Australian perspective, for those who don't know, it's a user pay system basically. So if a migrant wants to get a visa, they have to get a medical done, they pay for these tests themselves. So we're not so worried about that in terms of it. So we haven't even looked at that perspective of it. I think the other thing we except for the refugee population where we pay for those tests, what was interesting in the data is the refugee populations have about 1/3 the rate of LTBI positivity in both the US and the Australian data, which surprised us in some respects. But it may be that the cohorts, again, we're screening. The last couple of years we've been doing many more from the Middle East who have lower TB rates. I think I mean, there's loads of studies that we look about the cost effectiveness, but when we look from a pre-migration screening perspective, we know on average the cost of the test is about, for IGRA, is about $20 US. And it's a one-stop test. They don't have to come back, whereas for TST it becomes much more expensive because they have to come back, and there's a social cost of having to stay around to get their test read from they've travelled a long way away. But sorry, thanks.
I see a question here.
I think we've lost our volunteer.
Maybe I can just ask the audience. I had not see who is convinced LTBI screening. Maybe you raise some hands if you think that LTBI screening migrants is a way forward. I see one hand. That's good. Okay. Who's confused? Who's confused after this session? Okay, some people are. So, but there's a question here. Maybe you can have this.
There's been lots of discussion about the heterogeneity of migrants and who they are. And I wondered, apart from country of origin, how else we can collect, what type of different data we should be collecting on who these migrants are to find the moderate risk group that you were talking about before.
Yeah, maybe take this one.
Oh, there it is. I think you have to answer the question differently if you're looking at answering through improved surveillance systems, where I think there is it's a limit on how much you can ask for beyond country of origin. If you could throw in, at least some of the known risk factors that are not too difficult to obtain information about, if there could be some socioeconomic indicator, then that would be helpful. But I do think to get the granularity that you need, you also actually need to design research studies to really look at and think about both the risk factors for infection that would drive the prevalence of TST or IGRA positivity, and then the risk factors in terms of progression. So I don't have a clear answer about what the proper ambition level should be, but I think the talks here today have illustrated that actually we need a lot of data on all those things in order to really get rid of the confusion.
One of the things, sorry, just to answer Jess as well. One of the things that we do collect in the pre-entry data is the type of visa that they apply for, which in a way can be used, or some of it can be used as an indicator for socioeconomic status. I'm hesitating slightly because it's not actually translatable directly. And what we've recently done is we followed up a cohort of screened and cleared migrants who then migrated to the UK over time, 4 years or so, and look at the reactivation rate. And we did find that there is some correlation of those people that reactivate and visa status within that. So that's also it's a bit of a puzzle. I think we are not collecting near enough information that we can confidently have a very good pattern for that. So the question is a very good one, Jess. But we are, with the data that we have, we're doing what we can.
Okay, we can take one last question, and then we have to close this ceremony. This
Thank
session.
you. Kevin Schwartzen from Montreal. Thank you all for excellent talks, really top-notch. I think I'd like to perhaps raise something that Dr. Lonroth touched on, but may go even further, which is the prevention paradox, because I think there are data from the United States and to some degree Canada suggesting that in fact the bulk of reactivation TB we're seeing is in long established migrants, so that in fact the epidemiologic impact of screening new migrants only may be somewhat limited, and also in terms of this has major implications for cost effectiveness in that it will be a tremendous undertaking, a huge undertaking to screen established migrants, even if selection is done by age or certain risk factors. So I think that has to be considered as well, the balance between what TB is due to reactivation soon after arrival versus that in people who are established migrants and what their contribution to the TB burden is.
Thank you. Unfortunately, we have to close now in the interest of time and for the room to prepare for the next session. So thank you all again for participating. I guess we could say that we are on this pathway from controversy to an eventual consensus, perhaps like the graph Dominic showed. And we look forward to a continued discussion with new evidence next year. So thank you all. And if we may please have the speakers up at the screen for a group photo before you leave the room. Thank you.